Mention the duties of a doctor with regard to administration of anesthesia. Outline the procedure of to investigate anesthetic death. Complaints of malpractices connected with anesthesia may arise from death or illness caused by anesthesia used, burns, explosives, or injury caused to the patient when he is unconscious. Modern anesthesia is complex and but no means free from danger. The following precautions are necessary. As far as possible, an anesthetist should be a specialist. He would not be under the effect of drug or drugs while on duty, must possess the requisite experience for the procedure. A child aged 2 years were administered general anesthesia to permit an operation for the repair of a hernia in a critical situation arose during the operation when the child's heart stopped beating. This was corrected, but the child remained unconscious until his death a month later. At autopsy, it was found that death was due to cerebral softening, probably due to lack of oxygen anoxia during the operation. There had been a failure to change from an MDE to a full cylinder of oxygen due to incapacity of the anesthetist who was a drug addict. Anesthesia was charged with the manslaughter on the ground that his condition and the manner in which he administered the anesthesia showed that utter grade disregard of the patient's safety and was found guilty. Bearing emergency, the same practitioner should not administer anesthesia and also performs the operation. If he is employed by the surgeon, he must put down in writing the surgeon's instruction as regards anesthesia or the anesthetic solution to be used and the procedure for the same. If he is employed by the hospital, he must use only the procedure which are authorized by the hospital. If he is a specialist, he must select the anesthetic and procedure which he considers to be the best interest of the patient. Before administration anesthesia, he must properly identify the patient, obtain his consent, informed consent, save in emergency, examine her physical fitness, the respect to his disease, infection, allergy, or no specific condition contradicting onto the procedure or calling for special precaution. One person has to be operated on deflected spectrum in ENT OT. Another person was in surgical OT for a testicular baby. When the person was called, the testicular specimen was removed. The patient was unaware as there was a Fox pass. Both the patients have similar name and one entered by the other called NCHS Surate. He should position the patient carefully and check the drugs to be given, including bottles and cylinder. He should satisfy himself that apparatus through which the anesthesia is to be administered is correctly set up and such faults can be observed are duly corrected. He should also take precaution to prevent the static by electrical spark and burns. He should make sure that the proper drug is administered in the right manner, right site, right quantity, and at the right time, taking advanced precaution to avoid any mishap during the procedure. He should satisfy himself that adequate first aid equipment is ready for use at a moment notice and the help of another person, preferably a doctor or trained nurse, is available in the case of emergency. It is duty to see that the patient is safeguarded till he recover enough from the effect of the anesthesia to be felt safely to the care of the nursing staff or relation. This aspect of care is too often neglected during anesthesia on a female patient. A nurse or female relation should invariably be present unless the doctor happens to be a female doctor. All deaths under anesthesia must be reported to the authorities. Investigation of anesthesia. The disease called anesthesia death can be classified into two groups: death due to anesthesia, death associated with anesthesia, and surgical procedure. Death due to anesthesia. It is the responsibility of the anesthetist to maintain adequate anesthesia, adequate respiratory function, proper functioning of the anesthetic apparatus. Death can be attributed to anesthesia, may be due to anesthetic agents, the technique and apparatus, and some functional problems. Anesthetic agent. The direct action of the anesthetic agent may sometimes result in cardiac arrhythmia and cardiac arrest, such as occurrence with the halothane, especially in those cases where it has been administered earlier, even years before. Muscle relaxant, especially succinylcholine, may give rise to malignant hyperthermia. Succinylcholine causes malignant hyperthermia, resulting in death. In such a malignant hyperthermia, all forms of sensitivity are genetically controlled. The importance of taking a good pre-operative history cannot be overemphasized. Technique: hypoxia due to obstruction of the airways or faulty gas connection commonly results from carelessness, lack of experience, or in unfamiliarity with the equipment. This is the most common but avoidable cause of fatality in medical practice. It is not commonly realized that an apparently satisfactory induction of anesthesia may due to not such as to the presence of anesthetic, such as the absence absence of adequate oxygen. Unless this is correct, the patient may suffer from the immediate or long-term effect of hypoxia. Equipment. Unfamiliarity with the equipment common lead to mechanical problems such as nicked pipe, cross tube, overdosage, malfunctions, and apparatus and explosion. These are potent causes of avoidable fatality. Functional problem. The common problems related to vagal inhibition, obstruction of the glottis due to spasm, tube or vomit, cardiac arrhythmia, hypotension. Unconscious patient poses a special problem in regard to anesthesia as he is unable to take corrective reflex against inhalation of foreign material. Death associated with anesthesia. These are deaths which cannot be readily attributed to the anesthetic agent. They may be due to injury, condition of the patient, post-operative events, surgical mishap, and unforeseen problems. Injury with increasing complexity of life, where disputes are settled in a violent manner. The injuries themselves may be a result in death. With anesthesia and problem playing no part, the surgical procedure is usually undertaken in the hope that some miracle may occur and the patient's life may be saved. Condition of the patient. Sometimes the physical condition of the patient, old age, diabetes, high blood pressure, etc., does not justify the risk of procedure, but the operation is undertaken as an emergency. For example, in case of strangulated hernia. Post-operative events of fatality due to phlebothrombosis, pulmonary embolism, hypostatic pneumonia, etc. may neither be related to anesthesia procedure or to surgery. Surgical mishap, inadvertent tearing or cutting of a major blood vessel may result in death. One case in Bombay Hospital, Mumbai, India, while resetting a cervical rib, the subclavian artery was cut, resulting in uncontrolled bleeding leading to brainstem death in 10 days' time, the patient remaining unconscious throughout despite several blood transfusions. Unforeseen problems. Sufferers from the hemoglobinopathies, especially sickle cell anemia, are unduly susceptible to low oxygen tension in blood. This may pose a hazard to the unwary surgeon or anesthetist. Coronary artery thrombosis may supervene in a patient operated upon injuries. Transfusion hepatitis is not known. AIDS infection through transfusion is a distinct possibility. Delirium tremens may supervene in operative management of fracture of the leg in a patient addicted to alcohol. Emergency coronary artery bypass graft following a myocardial infarction or an operation for a relief of bile duct obstruction in a jaundiced person may prove fatal due to the disease process itself, even with or without a surgical intervention. In all such cases, the risk is either unforeseen or undertaken on account of the urgency of the situation. Investigation of the so-called anesthetic death is by no means easy. The dividing line of responsibility between the surgeon and anesthetic cannot be well defined. While the surgeon is responsible for his decision to operate, the extent of operation, whether to complete or abort it in the event of a problem, if he is guided by a anesthetist as to the patient's preoperative state, his condition during the operation, to maintain the patient's physical state by intravenous fluid replacement therapy is a function of the anesthetist during operation and of the surgical team thereafter. The presence of the surgeon, anesthetic, forensic pathologist to establish essential so that argument can be reached out to what was actually found at autopsy. There should be a free and full discussion between them as regarding the event related deaths, functional problems like vagal inhibition, spasm of the glottis, cardiac arrhythmia, hypotension may have no trace at autopsy. The pathological evidence is mainly intended to discover natural disease, to exclude mechanical blockage, demonstrate morphological changes in the brain due to hypoxia, and this include a diffuse alveolar leukoencephalopathy of the cerebral hemisphere, severe leukoencephalopathy of the cerebral hemisphere, demyelination of and obliteration of the axons, and infarct of the basal ganglia. The following guidelines must be kept in mind. It is essential that the surgical and anesthetic device indwelling needles, intravascular cannula, self-retaining catheter, endotracheal tube, monitoring electrode, etc. that may have been introduced in the patient should not be removed before autopsy, as their proper placement and patency may need to be checked. In case of suspected malposition of an endotracheal tube, a pre-autopsy X-ray and epilateral view is necessary. In case of failure of any equipment, expert examination essential. Pathologists may find a significant pre-existing disease, lung diseases, ischemic heart disease, hypertension or diabetes. It is then necessary to determine if it is noted or not. If not, whether it would have been noted before the operation. Care must be taken to dictate Any surgical emphysema, pneumothorax or air embolism where infusion or transfusion mishap is suspect, a possibility of air embolism should be considered. Toxicological analysis may indicate overdosage of the anesthetic or other therapeutic agent. A preoperative blood or fluid sample, if necessary, are helped to check blood group in a transfusion mishap to assess any biochemical or enzymatic abnormality. Example, creatine phosphokinase in a malignant hyperthermia that may be responsible for death. Thank you.